So just want to thank you all for coming. Welcome to the webinar. Dr. Cosgarea and I are just going to be speaking about shoulder injuries in recreational athletes, but because we are really kind of focusing with you guys at Meadowbrook on the swimmer's shoulder, just because of the legacy of Meadowbrook being, kind of focused around the swimming population. So just a couple quick numbers for you. In USA Swimming's population, according to their registration, we've got over 330,000 swimmers registered, but only 12,200 are over age 19. Now, that's kind of looking at the younger population. When we go to the US Masters population, we have greater than 59,000 Masters level swimmers. And I think that most folks that are probably talking to us right now are going to be in that group, and maybe not registered, but still lap swimmers, a little bit older, looking for the fitness, trying to keep themselves healthy. That's who we're kind of aiming at. Interestingly, in that population for US Masters swimming, the most populated area is between 55 to 59. So a lot of folks keeping themselves healthy in the pool. So again, we're going to just talk a little bit about shoulder pain, what that means to us when we're in the water, especially so that we can address any problems, hopefully, before they actually become limiting to anything that we're doing. So the most common thing that we're going to see with swimming is the shoulder pain, mainly because of the number of rotations that we take with the shoulder. And by and large, we want to kind of look at that as basically one shoulder revolution per yard that you swim. So if you add up your yardage, just simply, figure that that's the number of times that you rotate your shoulders, and you can probably divide it in half, one for your right shoulder, one for your left, but that's a lot of repetition that your shoulder takes, okay? So when we start looking and talking about this, we're looking for what mechanical trigger may have occurred. And the most common ones are increasing distance and increasing frequency when you are back in the water. So when we start kind of getting to that point, we can have, you can have collisions in the water if you happen to be circle swimming. Sometimes you hook arms, that sort of thing, but that's not common. The other ways that we get hurt are with trauma, which usually are going to happen outside of the water. That would be a fall or something like that. But what we want to look at when we're looking at folks for shoulder pain, especially in swimming, is we want to look for specific stroke that causes the pain. And we're also going to pay attention to what part of that stroke is causing the pain. So does it occur as you're entering the water out in front? Is it as you're pulling through? Is it as you're recovering back up and around? Because that gives us clues as to what is actually going on underlying that shoulder problem. So when we talk about shoulder pain, we like to kind of delineate whether we have an inflammatory process versus a mechanical process. Now, the difference there is that when we have an inflammatory process, that is often present even when we're out of the water, oftentimes without much activity. So you can have pain at rest. It will tend to disturb or wake you from sleep. And when you do an activity, it tends to actually make the symptoms worse and then last for a very long time afterwards, okay? Now, comparing that with a mechanical problem with the shoulder, that's going to be something that you're going to get pain when you do a specific activity, okay? And this is what I was talking about with a specific stroke or a specific part of the stroke. So if we have mechanical pain, very frequently it will show up in one part of the stroke and the rest of the stroke will actually feel pretty good, okay? So we're looking for where it's limited, where that specific area of movement, whether it's in or out of the water, it doesn't really matter. But we're looking for something mechanical that's actually triggering it there. And in those cases, that pain is often short-lived, meaning it hurts while you're in that position. And then when you get out of that position, it actually goes away quite quickly. So it's not going to linger for hours and hours afterwards. Continuing with that, we have the common diagnosis that we hear about: tendonitis and tendinopathy, impingement syndrome. As we age, we worry about some arthritic changes in the shoulder. And then of course we have the ubiquitous swimmer's shoulder, which is a diagnosis that means you have a sore shoulder and you like to swim. So that's a pretty non-specific problem. When somebody goes, oh yeah, swimmer's shoulder, yeah, I had that. Well, you probably actually don't have the same shoulder problem as the other person at that point. And that's okay. That's where we start looking at delving into where is the symptom, what's going on there. So when we're talking about tendonitis versus a tendinopathy, tendonitis is more specific. That's just saying that the tendon is highly inflamed. That's more of an acute problem. A tendinopathy is basically the broad term for any sort of tendon pain that we have. So don't get too hung up on that. Really what we're looking at with tendinopathy is whether there's a pathological condition that's underlying, which usually there is some. It could be atrophy, could be overuse, but really what it indicates is that that tendon doesn't handle stress loads well, okay? It doesn't mean that it's necessarily damaged or torn. It just means it's not doing what we expect it to do, okay? In that case, it could be what we would call a tendonitis, where it's more acutely irritated, or it could be something called a tendinosis, which is more like a chronic sort of irritation on the tendon that starts to show some of the signs of atrophy of that tendon, or changing of its ability to handle that stress. So, okay. So with that, again, the most common cause of tendon pain that we see in swimmers is the supraspinatus tendon. That's a very specific tendon that is pretty much right up across the top, comes across the top of the shoulder. Most folks are going to point to the side or peak of their shoulder here, and they may have some pain that refers down into the area of the sleeve. In the studies by Sain et al., it basically said that tendinopathy was induced by large amounts of swimming training. Okay, so that could mean increasing your training, especially like starting up again after a long time out of the water since, well, we've all been forced to stay at home and not able to get back into a pool. So realize that as you're starting back up, you're really going to want to kind of remember that you haven't been in the water for at least 2 months. Maybe you've been doing some training outside of the water, but it's not quite the same. And every swimmer that gets back in the water realizes that everything they've been doing outside of the water really doesn't train them the same way as the water does. So when you're getting back into the water, just remember, take it slowly, kind of reduce your yardage. Don't think you're going to pick up right where you left off, because that's just not kind of a viable option for your shoulders to survive there. So, and again, it's really related to that intensity and duration of load on that tendon as to how irritable it can get. So again, moderate the load and the duration at first. Make sure as you're getting back in, you're paying attention to those. So when we look at a shoulder, the shoulder has a very large range of motion. In fact, the joint has the largest range of motion, and it's unique in that it allows us to do such a great range there. So because of that, with that ease of motion at the shoulder joint itself, it can often compensate for other parts of the body that aren't functioning well. Now, the reason that I'm going to bring that up is because oftentimes we'll pay attention to the shoulder as if it does its thing in isolation. So we'll pay attention to a tendonitis and you do all the treatment for the tendonitis, but you kind of forget that the shoulder blade has a role in how it works. Your neck has a role in how that works. Your upper back and your rib cage have a role in how that shoulder is positioned and how it's working. So what we're looking for is, don't just focus on where the pain is. Also take a step back and go, okay, what changed? Was it just increasing yardage? Or did I actually change my stroke technique? Have I added a new stroke? Where am I not moving? Have I, do I have neck pain? And then I'm trying to swim and my shoulder's starting to bother me after my neck. Those sorts of things we want to pay attention to. So limited, oftentimes with shoulder mobility, when we're looking at younger swimmers, we're worried about them having greater shoulder range of motion. As we age, we tend to get toward the side of limited shoulder motion. And when we have that limited motion, again, that can pose some problems for those great ranges that we need to use through the water. So again, the swimming requires that huge range of motion and a complex coordination of all of the muscles and the joints to allow you to do your strokes properly. So our shoulder complex is actually a group of joints that we look at together, which includes the ball and socket, which is the shoulder proper joint, that's up here. Then you have the collarbone as it attaches in, so that has a joint on the inside and the outside called the sternoclavicular and acromioclavicular joints. They actually are the connection point for your shoulder blade to be able to move. And then we have kind of a pseudo joint, which I will, it's kind of a false joint, which is the scapulothoracic joint. We don't consider it a true joint technically, but we get a lot of motion through how that shoulder blade can move and position, and that helps us to place our arm correctly in space. So as we move on, I had already mentioned that we have a complex coordination of movements and joints. There are muscles and joints that we need to work here. So first place that we actually need to pay attention to is the neck, so the cervical spine, because it gives rise to a lot of the muscles that control our shoulder blade, okay? It also gives rise to all of the nerves that control the shoulder blade, and down into your arm. So when we look at function of that shoulder, if we have a problem in the neck, it can manifest out at the shoulder. So that's something that we just need to keep in mind, that we don't want to kind of overlook what's going on in the neck. So as you're hopping back in the water and you're swimming and you're like trying to breathe to your right side, and you're going, my neck is really stiff going that way, and my right shoulder hurts. Don't think that those are two separate things. Try to think about those being tied together. So as we move out from the neck, we get to what we consider the brachial plexus, which is that bundle of nerves that run out from the neck into the upper extremity. So I'm gonna see if I can get my cursor over here so we can see the yellow here coming down. Those nerves run underneath of your collarbone, underneath of the pectoralis minor muscle, which is kind of sectioned away here, and right over top of your rib cage, okay? So there are some tight areas right here and right here. And I don't mean tight like you need to stretch them out. I mean, they just have tight tolerances. It's not a whole lot of room there. So when we have something that can be causing some irritation in the neck, sometimes these scalene muscles right here get tight, and they will start irritating a bit there. And then as those nerves are sending their messages, it just starts messing with how you want to use the muscles at the shoulder, which can just kind of mess with some of that coordination. As we go further down, again, we can look at the upper thoracic spine, which is the upper back area right here, and the rib cage, also acting as anchoring points for what we call the axioscapular muscles. Those are the muscles that run from your trunk up to your shoulder blade. So here we have lower, middle, upper trapezius. Here's levator scapulae. These guys are the rhomboids. So we hear a lot about rhomboids and middle traps and doing work here. You might not have heard so much about levator, but that guy's really important because if it's tight, it'll tend to hold your shoulder blade in a position that gives us a little more pinching on the shoulder itself. Any place that we have a limitation through that upper rib cage or upper back means that we have to actually move our shoulder just a little bit further to make up for some of that limitation. So again, this is where we start looking at it and going, okay, if you're not moving elsewhere, your shoulder can be the compensatory place. And then that guy can get irritated by doing more work than we typically expect the shoulder to do. So when we start talking about shoulder blade problems or scapular problems, what we're looking at here is that abnormal shoulder blade motion is actually common in pain-free swimmers, okay? So it happens all the time for us to have some little variations on how our shoulder blades move. The prevalence actually increases as you go through a training session, which tells us that actually fatigue probably plays a role in how well we control the shoulder blade. So the interesting thing is we really don't have any research now that currently tells us if having the shoulder blade problem leads to a shoulder problem, or if you have a shoulder problem to begin with, if you start using your shoulder blade in a different way, and that's why we see the shoulder blade problem. So you might actually be using the shoulder blade to compensate for the pain in the shoulder, or you could be moving the shoulder blade oddly, and that could be contributing to the shoulder pain. So the shoulder blade positioning is important because it allows us to keep the ball and socket together. Okay, so the socket is actually a portion of the shoulder blade. And we want to keep the ball from the arm kind of centered on that bone, okay? So as we use the shoulder blade, it can allow either more or less freedom of how that shoulder can function. So if our shoulder blade is in a bad position, say if it's rolled forward in a slouched sort of posture, that makes it much more difficult for us to get our arms up overhead. So, and that can go along again with that thoracic sort of curve as we get older, where our shoulders kind of round forward, and then we start going, my shoulders hurt, and oftentimes we just need to get ourselves taller from the lower back there too. The analogy I like to say, Maggie, can you be quiet? So the analogy, sorry about that. The analogy I like to use, and I've been talking about how things kind of compensate for, or the shoulder can compensate for other things. I like to use an analogy of an assembly line. So if you think about movement in our body occurring like an assembly line would, every part has its job to do, every muscle, every joint, every nerve. They all have to contribute together and get themselves moving well. So imagine if you're on the assembly line and you've got Tom, Dick, and Harry ahead of you, and they all go on coffee break. So now you're left doing Tom's job, Dick's job, and Harry's job, and your own. So you do all 4 jobs repetitively. Eventually, you're going to get really angry, and you're going to go complain to the foreman. That's kind of what can happen when the shoulder starts taking over for these other things that aren't working well. So again, just keep in mind that this is one of those things where we go, shoulder pain is, you know, kind of our focus, but realize that there are other contributing factors to that. And we want to make sure that we get Tom, Dick, and Harry back online as well, so that they're doing their work and the shoulder doesn't have to do 4 times its normal work. So as we look at some of this shoulder blade positioning in the water, here are a couple positions that just show how the body can be in one line and the arm end up in a different plane. So here we've got on fly entry, shoulder blades and body kind of pointing down, arm getting pulled up by the force of the water. That would actually kind of put a high stress across the shoulder joint. Same thing here on the backstroke, where body roll is coming across, the arm is reaching a little too far back there. That tends to put a little bit more stress across the front side of the shoulder. So we can change some of these things just by making sure that our body position is better and take that stress away from the shoulders. So again, in this case, you have to have the shoulder blades stable, okay? Oftentimes, if some of the muscles on the backside of the shoulder blade are much stronger than the shoulder blade muscles themselves, those axioscapular muscles that anchor the shoulder blade, we'll see something that looks like this. This is scapular winging. And that's occurring as this girl is kind of working on her entry point for fly, okay? So we don't want to see that tipping, especially when she's up in this position. So this gentleman is working on her fly entry, but I would say, I think she needs to fix this first before she worries about that. The other thing that's kind of interesting on this picture is that you'll look down here at her armpit and you can see that the armpit kind of doesn't stay hollow. That right there is actually the ball of the ball and socket. It's actually kind of sliding down off of the socket at that point. So this girl actually has an unstable shoulder and an unstable scapula. So those things need to be addressed in order to kind of get this back in check. And I would start here first, because if we can't stabilize that scapula, we're going to have a really hard time using the rotator cuff to stabilize the ball. Rotator cuff's anchoring point is on the scapula. So if that shoulder blade can't stay still, it's like running in deep sand. It's going to be moving the shoulder blade rather than keeping the ball on the socket there. So again, some simple things to kind of think about to help this out. So again, here we've got somebody relatively flat in the water, arm coming below the water there. So simplest thing to change in freestyle and backstroke, our most common strokes, is to improve our body roll. Exaggerate the body roll, especially on backstroke. Most folks tend to stay a little too flat there. So if you can exaggerate body roll just a little bit, that takes some of that stress away from the shoulder. Anytime the arm is going behind your back, you need to think about leading it there using the shoulder blade, okay? Again, if we can work on keeping ourselves taller through the upper back, try to avoid that curved posture here. So these things all help to position the shoulder blade correctly, which takes that stress away from the shoulder. So as far as impingement syndrome, every swimmer gets impingement at some point in the stroke. Impingement is actually more the rule than the exception. It is normal in certain positions for us to get some impingement on the tendon. The impingement itself may or may not be a problem. It has to do with how the tendon is tolerating that stress. So anytime we take our arm up and across here, we're technically pinching on that tendon. But this one gives me no pain. So is it a problem? It's really not a problem unless I keep doing it and doing it and doing it and causing it to get aggravated with it, okay? So the interesting thing is that everybody gets into an impingement position sometime during their swim stroke, but over time, your body will actually change the stroke just a little bit to avoid that impingement. So your body's constantly adapting, even as you're going through your swimming set. It's not just adapting, you know, over the next 6 weeks. When you start, you might have a different stroke than when you finish your practice. So those are things to just kind of pay attention to as you're ramping back up, especially here. It's like, let's make sure that your swim stroke feels good, looks good, is under control, and, you know, start ramping up your distance very slowly as you're returning to the water. So I'm just going to go through 2 quick case studies because this will get a lead into what Dr. Cosgarea is going to talk about as well. So the first one is a 68-year-old female with left shoulder pain. She had increased her swimming through last summer, had worked up to 1,200 meters 4 times a week, but she started with shoulder pain that actually got to a point where she was unable to swim. So when she came to me, she had not been swimming for about 3 months. She had no pain at rest. She did have pain with reaching behind her back, putting on a jacket, and performing yoga or swimming. It would actually disturb her from sleep. She had noticed initially that she had some tingling in her hand, but that had subsided. And she rated her pain at a 7 out of 10 during activity. Now, a 7 out of 10 will stop you from doing your activity. Okay. If you get to a 5 or a 6, you figure you can work through it. Once you start getting a 7 or 8, you don't want to do that activity anymore. Okay. She had previously tried PT, but really did not have any change in her symptoms. So what we saw with her was that her left shoulder blade was kind of malpositioned. It was held up, rolled forward, and tipped down. Now, tipping down is actually caused by that tightness in the levator scapulae that I kind of pointed out earlier. So when it starts kind of rolling down toward the shoulder, we end up with a threatening angle on that shoulder. Her range of motion actually looked pretty good, except for reaching behind her back. Her strength was normal in most motions, which is a good sign because, again, we're not looking at something being torn in her shoulder or a rotator cuff tear in that case. But she had a greatly limited internal rotation at only 15 degrees. Now, she did have an impingement sign that occurred without any internal rotation. So if we took her arm across, this was as far down as she could roll her arm. We want it to be able to roll down here. And as far as she could come down was to here. Now that's important because you need to have that internal rotation to be able to perform a swimming stroke, okay? She also had noticed that she had some neck pain going along with her symptoms. So with her treatment, I worked with her neck and upper rib cage first and had her do some exercises that she could actually do without provoking any of the shoulder pain, including learning how to breathe again from her diaphragm or doing belly breathing. Over the next several visits, we worked more on the coordination of what she did with the shoulder blade and the shoulder together. And by her 9th treatment, she was able to do all of her exercises, able to get back into the water without pain, and even could do that position with yoga and not have pain in her shoulder. So she could come across, rotate her arm back, everything had been restored that way. So again, the key for her was starting actually on the neck and the upper rib cage rather than going directly at where she thought the pain was generated from. So she was coming in with shoulder pain, but actually some of these other limitations were forcing her shoulder to do way too much work. So the second patient was a 69-year-old male who had right shoulder pain. He was also a swimmer, but he had injured his right shoulder falling off of a lat pull-down machine. So he had gotten onto the pull-down machine, leaned back, and it had too light of weight on it. So he kind of just kept falling backward, put out his arm, and caught himself with his arm. He was unable to swim after that, had pain immediately. So again, difference here is we've got some trauma that's involved. He had pain immediately. He had a prior, so with that prior fall, he then went to the doc, was not Dr. Cosgarea, but went to a doctor. They did a cortisone injection because of that persistent pain, still had limited motion, but he did not have pain with sleeping. So that's a little different than our first case. His passive range of motion was perfect. His active range of motion was painful. So he could not move his arm easily on his own. So he was very weak with rolling his arm away from the center, raising it to the front, or raising it out to the side, and had pain with those motions, especially with rotating out. And probably the other thing that was most noticeable is that he had hollowing or atrophy right up here, kind of in this region that goes behind the shoulder in that muscle called the supraspinatus. So when you have hollowing, that's usually a sign that something has damaged the muscle. So we did some work for a visitor too, tried to do some of the shoulder blade re-education, seeing if we could get things stabilized that way. He did rows, wall push-ups, some side lying exercises, but he had no changes in his symptoms or his strength. So we referred him out to the doctor. Now, again, at that point, he's going to go through diagnostic testing to determine whether anything can be done with further PT, or whether we need to look at something more invasive like another injection or some sort of surgical intervention. So, and I'm going to stop right there, because as soon as we start talking about surgery, I'm in over my head, and that's where Andy does his best work. So I am going to punt over to Andy at this point and let him pick up from there.
Thanks, Scott. That was outstanding, as always. And let me get up my talk here. Can you see that, Scott? You're muted, Scott. Do you see it?
I do
Yep, we see it.
It looks like you're up. Yep, you're up good,
Great.
Andy. You got it.
Okay, good. So thanks, Patty, for the introduction. And Scott, that was an excellent talk. I always learn a lot every time I talk to you on the phone or watch you speak. So thank you very much. This is the place that I miss. We all recognize this, I think. And these smiling faces on the wall here, these inspirational smiling faces, Michael and Allison and Katie and Ian. And the wall also has these incredible inspirational sayings like excellence is an art won by training and habituation. We all believe in this. Excellence then is not an act, but a habit. I use these slides when I'm lecturing my residents. I'm really looking forward to getting back to Meadowbrook, hopefully very soon, Patty. I'm going to carry on from where Scott started and talk about a couple of common shoulder injuries in recreational swimmers. And the first is rotator cuff, and then the second is labrum. Scott talked about the rotator cuff. We sort of think of tendon problems in general as tendinopathy. And then there's sort of subsets of that, tendinosis, tendinitis, and Scott mentioned swimmer's shoulder, which is sort of a wastebasket diagnosis that includes all sorts of shoulder pain. But I think the important thing to remember is that it's a chronic process that occurs over decades. It's probably related to the number of laps that we've swum or the number of pounds that we've lifted or baseballs that we've thrown. And it's a normal sort of wear and tear process. People can have an acute onset or acute presentation of pain, even though it's sort of a chronic process. And that can be confused at times with the more dramatic rotator cuff tear. So in the case of a tear, it's usually an acute injury But oftentimes there's underlying a chronic degenerative process, so weakening of the tendon that makes it easier for the rotator cuff to tear. And these tears can be partial thickness tears, they can be full thickness tears. And one of the most important points I want to convey tonight is that surgery is not always necessary. In fact, very often not necessary when it comes to successfully treating a rotator cuff tear. So to pick up a little bit on the anatomy that Scott was showing, here's an example of one of the 4 rotator cuff muscle tendon unions. The red here is the muscle, and the white is the tendon. And what happens is the muscle generates the tension. It gets transmitted through the tendon to its attachment on the bone. And then that's what moves the bone, in this case, the humerus. As Scott mentioned, the supraspinatus is the most commonly involved in this tendinopathy and in rotator cuff tears. And when a tear occurs, it happens at that attachment point. That's the vulnerable part of this muscle tendon bone unit, the attachment point. And it can occur from a traumatic fall, as like the case that Scott showed, or it can be an overuse type of thing. And many people with rotator cuff tears don't recall any specific incident. They just suddenly realize that they've got chronic pain in their shoulder. So if we go one layer deeper anatomically and we move the rotator cuff muscles and tendons out of the way, we can look at the ball and socket joint, the humeral head, and then the socket called the glenoid. And there's this tissue, a tough fibrous tissue called the labrum that sits around the periphery of the socket. It deepens the socket and it provides stability. It's sort of like the ball and socket joint is a round ball sitting on a fairly flat socket, and the labrum deepens it and provides stability. But it's also vulnerable to injury if the shoulder were to dislocate. Oftentimes the labrum is torn when this occurs, and this can occur with a dramatic dislocation episode or an overuse injury, such as throwing a baseball or swimming. So another view here of the labrum surrounding the socket, and it's almost like this O-ring here. And a bunch of different problems can happen with the labrum that we can notice. So you can have an episode where the shoulder is loose or hypermobile, often been called in the past double jointed, and that can result in the labrum itself being loose and incompetent or frayed. And hypermobility is common in swimmers. It's fairly normal in swimmers, but it can reach the point where it predisposes to pathologic instability episodes, painful episodes where the shoulder slips in and out. A slap tear is a tear of the labrum in the top part of the labrum, and this is something that you hear about in baseball pitchers frequently. It also occurs in swimmers, and it's usually an overuse type problem. And then the dramatic acute event that occurs when the shoulder dislocates, it pops out, almost always tears the labrum in the front or the back. And when you tear the labrum, you compromise that stabilizing force, and it makes it easier for the shoulder to dislocate again and again. And here's a kind of a cool video. I want you to look at this boxer's left shoulder and watch what happens as he swings wildly with his right arm. The left shoulder pops out, and his opponent comes over, pops it back in place, and there's his reduction. He's back ready to go. That's a dislocation. Scott took us through a couple of case presentations, and in general, what we do when we're assessing a patient is we get their history, do the physical examination, find out what causes the symptoms, and then try to correlate that with things that we identified during the examination. Scott mentioned loss of internal rotation, for example, and then obtain our radiographic studies, x-rays, MRI, sometimes CT scan. And then based on that information, provide some sort of intervention. And the first intervention is simply activity modification. And most of the time, that's something that people have already tried. They've backed off on swimming, or they've stopped swimming backstroke and switched over to breaststroke, or stopped kicking with a kickboard. The next modality or intervention that's incredibly helpful is physical therapy. And I would argue that over 80%, over 90% of patients who come to me with overuse problems with their shoulder benefit from and really are cured or at least managed with an excellent rehab program. And the mainstay of that is formal physical therapy. So I've convinced a lot of people over the years that they didn't need surgery by sending them to very talented people like Scott, who've been able to help them and keep them away from the operating room. Injections can be helpful from both diagnostic and therapeutic standpoints. And then, of course, if all else fails, we've got surgery. And so let me share with you some of the sort of radiographic workup. And I'm going to show you x-rays and show you some MRIs, because I want you to feel comfortable if you happen to be in a physician's office and they've ordered these studies, sitting down with them and asking them to explain them to you. So you see what's going on, you understand what's going on. So this is a normal shoulder on the left. There's the space between the roof of the shoulder, called the acromion, and the humeral head. And this is the area where the rotator cuff exists. It's between those two bones. And on the right, you can see the loss of that space and the arthritic changes between the acromion and the humeral head. That rotator cuff is completely torn, and it's been torn for a long time. You can tell by the changes in the bone. And then there's also the bone spur here. So the treatment for an individual with an x-ray like that's going to be completely different than somebody who has, say, an acute tear or someone who has a tendonitis. We rely on MRI to show us the soft tissue changes that we can't see on an x-ray. And we know that a closed MRI that surrounds you gives you better quality, more information than an open MRI, and that the bigger the magnet, the more powerful, the greater the value of the MRI. So for example, a 3 Tesla MRI is better than a 1.5 Tesla MRI. And occasionally we'll also inject dye into the shoulder before an MRI to sort of better outline the soft tissue structures and get more information. So let me take you through a couple of cuts of an MRI here to try to make sense of the anatomic drawings that you saw and the description of the different muscles that Scott gave you. This is the humeral head, and this cut is from the front of the shoulder. So you're going to see sequential cuts starting in the front and working your way back. This next cut here shows the supraspinatus tendon, this black structure attaching to the humeral head. This is the labrum, and here's the biceps tendon. These are things that you can ask your clinician to show you as you're sitting down in the office, as they're talking to you about what kind of treatment you might need. Here's the acromioclavicular joint Scott mentioned, the AC joint. Here's the muscle of the supraspinatus and the tendon of the supraspinatus. So it goes from muscle to tendon to bone. This is the upper part of the labrum, and then the infraspinatus muscle. And then finally, the last cut coming to the front of the shoulder. This is the acromion, the muscle, it's the roof of the shoulder. The infraspinatus tendon attaching to the humeral head, the infraspinatus muscle. So to sort of summarize, a normal rotator cuff looks like this. It's got a uniform dark appearance, a constant thickness, and this uninterrupted contour. This is what you'd like to see when you go to the doctor's office having had an MRI obtained. Some examples of abnormal rotator cuffs. This is tendinosis. This is degeneration of the tendon, some wear and tear, sort of an abnormal signal in the tissue, but it's not torn. There's no full thickness tear. And then a more advanced case of tendinosis.
It's torn.
This can be completely asymptomatic. You can be walking around, swimming, biking, lifting, doing all your normal activities and not have any pain. So the presence of these abnormalities on the MRI don't necessarily mean that you have a functional problem. And in fact, this can be a totally normal situation. Here's an example of a partial thickness rotator cuff tear. It's about halfway torn through. And then on the right, a full thickness tear. the two arrows show where the end of the supraspinatus tendon is supposed to be attached. So it's torn off and it's retracted, kind of like a rubber band springing back. And then you can also have a partial thickness tear that involves either the top surface, the bottom surface, or in this case, the actual central portion of the tendon. Doesn't necessarily need any specific intervention. Just it can be painful, can cause problems, but doesn't necessarily need surgery, for example. Tendon tears can be partial width, they can be complete width. There's a lot of variability from one tear to another, and the vast majority don't need surgery. Okay, moving on to labrum. So a reminder, it's that rubbery fibrous tissue surrounding the glenoid, the socket. And this is the area that we look at on an MRI for a labral tear. On the left, that's a normal labrum. And on the right, you can see the disruption of that normal shape and pattern and that abnormal white signal within the substance of the tissue. So physical therapy, incredibly important. Most of us will try to instruct our patients in a home-based rehab program to begin with. And many times that's enough. And when it's not, and if it's a significant problem that needs the hands of a professional like Scott, then we'll do a formal physical therapy referral and try to point you in the right direction. So Scott can do so much with his hands and with education and discussing modifying stroke technique, using modalities like ultrasound and electrical stimulation and razor and needling and all kinds of other stuff. So if that's not enough, if we need to get more information, we can consider an injection. And there are two basic types of injection. We can inject lidocaine into the joint, and there are different parts of the joint, like Scott showed in his diagrams. And the diagnostic injection can help us figure out where the pain is coming from. So it's not unusual to order an MRI and see abnormal findings in more than one location. So maybe there's a labrum tear and there's a rotator cuff tear, and it's not clear which of the two, or if either of the two, are causing the problem. So it's possible to take some lidocaine, inject it into the area of the rotator cuff, and then if that takes the pain away, we confirm the diagnosis of a rotator cuff problem and vice versa. That's the diagnostic side of things. By including cortisone in that injection, then we can get long-term or at least intermediate-term relief of the pain, 4 weeks, 6 weeks, 8 weeks, by decreasing the inflammation, decreasing the swelling, decreases the pinching, particularly in the supraspinatus, and maybe makes the rehab program a little bit more effective. But it may also result in this false sense of security. You can go out and hurt yourself without realizing it. Multiple injections cause tissue degeneration, weakening of the tissue. And studies have shown that if you have an injection before a rotator cuff repair, it can actually compromise the results. So you've got to be really careful with injections, and it's something to be utilized cautiously. So if all else fails, we've got surgery. And here's an example of an arthroscope that we use for arthroscopic surgery. It's a telescope, and there's a camera attached at this end, and it's inserted through small portals into the joint. This is the part of the scope that goes inside the shoulder or the knee or whatever joint we're looking at. And by doing this, we can almost always not need to make incisions. This kind of surgery can be done on an outpatient basis, usually with a general anesthesia and often a nerve block. So you could get 12 or 16 hours of pain relief after surgery. So I want to share a little bit of my world of arthroscopic surgery with you and show you some pictures. On the left is an intraoperative photograph showing the labrum. I've got this metal probe. The end of the probe's 5 millimeters, so it's quite magnified. And what I'm doing is I'm taking this probe with my hand and I'm feeling the labrum. It's sort of an extension of my fingers. And that's what a normal labrum looks like. In contrast, this is a torn labrum. You can see the fraying of the edge of that fibrous tissue there. And then here's a little video. Again, this is a torn labrum. My probe is in through one of those portals and I'm pulling on this tissue. It's not always obvious from an MRI whether it's torn or not. So we would typically make the final decision on what to do based on what we find at the time of surgery. So here's a case example. This is a 51-year-old triathlete who's had shoulder pain like most of us have had over the years. In his case, tolerable for 5 years. And he was out of commission for 8 weeks. And so that maybe that's his business schedule was crazy and was unable to get to the pool for 8 weeks. Or maybe there was a COVID pandemic and he was unable to get to the pool for 8 weeks. And anyway, he jumped back into his training program and started lifting hard, and suddenly his pain was much worse. He had pain with swimming, pain with attempts at lifting his arm, pain that awoke him at night. And so he ended up getting an MRI, and it showed this finding right here. So there's the supraspinatus tendon, and you can see that it's torn and it's retracted from its attachment point where the white arrow is. And this is a full thickness rotator cuff tear of the supraspinatus. So sent him to a physical therapist who did excellent work, but unfortunately, this athlete was unable to get back to the level of training that he wanted to be at. So he ended up requesting surgery. And this is what we found at the time of surgery. This is the edge of the supraspinatus, and this is the bony attachment of the humeral head. The black arrows are where that supraspinatus tendon is supposed to be attached.
Oh my God.
It's torn, it's avulsed off, and it's retracted.
Wow.
And so we repaired it. And this is what it looks like as we're doing the repair. Here's that torn edge of the supraspinatus tendon retracted to the right, supposed to be attached here. And these are 2 anchors. These are implant anchors. They're hollow screws made out of a material that's an absorbable material, would be reabsorbed by the body. Each of these is about 1/4 inch in diameter and about 1/2 inch long. And they're buried in the bone, and they're attached to these anchors are these heavy duty sutures. What we do is we take the sutures, we pass them through the torn edge of the tendon and tie a knot to bring the tendon back to where it belongs. So that's the leading edge.
Wow.
Brought down to the anchors, reattached, and the knots are tied. So that's what an arthroscopic rotator cuff repair looks like. In this case, this patient went home the same day after the surgery center surgery and started formal physical therapy 2 weeks later. It's typical that you'd need to protect the shoulder for a substantial period of time. So a sling for 6 weeks. And then assuming that the progress is made as appropriate, stationary bike within two weeks or so. It's at least 3 months before you can start running safely, and 6 months or more for swimming. And that's a general outline of a rehab recovery protocol. So thank you very much. Thanks, Scott, for your talk, and Patty. I do want to point out this paper here that Scott and I collaborated on several years ago. Scott's the first author on this, and he's too humble to point out how you can reach him. So there's his email address and Life Strength Physical Therapy. And we're happy to take any questions.